Good afternoon, good morning, and good evening, everyone. Happy World Environment Day, and welcome to this session, Sustainable Solutions from the Global South. I'm Diana Picon Manjari. I'm the International Climate Director at Healthcare Without Harm. When we were approached to put together a session on Global South solutions, I was very excited. We had heard that CleanMed Europe participants last year had asked to learn more about what health systems and facilities in other countries, particularly the Global South, were doing around sustainability and climate change. We come also at the heels of a historic World Health Assembly, where a new climate and health resolution was adopted by World Health Organization member states, which will see greater interest, demand, and accountability for countries around the world in both adaptation and mitigation actions. Well, today, we are delivering this desire from European health systems to learn about some of the actions that are being taken in health systems in 3 different countries, the Philippines, South Africa, and India. As I am thrilled to be here with the amazing panel we have put together for you. But before introducing our speakers, I have a couple of quick points that I have to share with you. Please note that this session is being recorded and will be available on this page shortly after the session has ended. In the panel to the right of your screen, there is a live chat tab. Please use that to add any comments or the question and answer, the Q&A tab, to send questions to our speakers. I will do my best at the end of the session to ask your question, so do let us know if your question is specifically directed to one or all of the speakers. If we do not have time to answer any questions, then the speakers are encouraged to answer them in the chat after the session. Otherwise, please feel free to also engage directly with any of the speakers or fellow attendees via their profile. Well, now, without further ado, I would like to introduce our first speaker. He is Dr. Glenn Roy Padasso, who is the Executive Director at Mary Johnston's Hospital. Welcome, Dr. Glenn. The floor is yours.
Good day, everybody. Thank you very much, Diana, for that introduction. And I would like to share with you what we're doing in Mary Johnston Hospital. Mary Johnston Hospital is in the Philippines. It has been operated since 1906. And we have had a great ride all of the time, but now it's looking at what are the possible solutions or sustainable solutions, I should say, with contributing to how climate change and health can come together. So just to show you that we are looking at 2 things. This is on energy and then on waste. So just to show you some statistics on our renewable energy, we have installed 1,070 panels all over our rooms in the hospital. And since 2022 to 2024, we've been covering around about maybe 30% of our needs in the hospital. And because of that, we're looking at an estimated environmental impact of carbon emissions which have been saved because of the panels, and an equivalent number of 8,000 plus trees which have been equivalent to planted because of this initiative. And also because of that, we have cross-subsidized also HIV/AIDS and TB for diagnostics and treatment for indigent patients. So we're doing a 2-pronged approach of looking at these 2 diseases with savings coming from our panels. So with HIV/AIDS, we're now maintaining around about 40 of them, 44, and 40 of them or thereabouts, I think, are indigents, together with our also TB, right? So they're enrolled patients and project beneficiaries that have been benefited because of the savings. Our next slide. Yeah. So our next slide would just give us what are some of our lessons that I'd like to share with you from this initiative. We started off actually with this initiative with looking at the possibility of climate change and health and coming up with a two-pronged solution towards maximizing whatever limited resources we have to broaden our sustainability initiative. So we were now looking at both healing the environment and also healing human health. At the same time, we are looking at, another lesson was to front load our investments to help our institution ease or maximize whatever limited resources there are for this initiative. And then the third lesson was that you would have to have the buy-in of our community. And this involves different stages, having different actors at the community level. And last but not the least, we are looking at planning for synergies as a lesson also that we are deriving from this initiative and looking at integrated approaches so that, while we plan for this financially, we're also looking at a self-financing mechanism for savings coming from renewables and energy. Our next slide will show us another of our initiatives. During the pandemic, we were looking at our PPEs and how we can, reduce the effects of plastics also during this time. And we saw that a lot of our medical waste was actually just looking at segregation as a possibility and education as a solution. So we were able to save quite a substantial amount of this plastic waste per category. And then the savings from, because of being able to segregate all of this into the right bags. And relative to that, we were looking at that other waste and also our supply of PPE. So we were able also to reuse our PPEs in order to lessen its effect both on the environment and on costing. So we were able to save around 6.9 million pesos during that time in COVID. Right. So just to show you the next slide, we'll see that waste management in this initiative, there were also lessons that we were able to get from this. And some of the lessons were, number one, during this time of COVID, we know that this disruption, which was really the pandemic, it led us to a lot of unrealized costs and challenges because we didn't really know how we would treat it. At first, we didn't know what the pandemic was all about. So we were just spending left and right. And that was an unrealized cost for us, and the challenges were so big. The second lesson that we were looking at is this pandemic is also an opportunity for organizing our health initiatives and how we can think green, so to speak, in order to lessen the effects of what our medical interventions are to the environment. And a third lesson that we can see from this is that we are looking at the consideration of integratedness of approaches. While we do this, we can do waste and we can also lessen its effect on the environment and therefore look at the better health initiative for us in order to move forward with helping out our patients. So I think that's it from my side, and I'd like to thank Healthcare Without Harm for this opportunity to share with you some of the things that we're doing in Mary Johnston Hospital. Good day.
Thank you so much, Dr. Glenn. It is really great to see how you were looking both at the maximization of resources and cost savings, right? And also the patient benefits and the community engagement that are required for those solutions to actually take place. And really looking at the pandemic also as an opportunity to really rethink how the operations of your hospital can improve, be greener, be better for patients and the community. Thank you. Yeah. Our next speaker is Tulsi Ravija, who is the Director of Operations at Aravind Eye Care System in India. Tulsi, over to you.
Thank you, Diana. So I'm from South India, representing the Aravind Eye Care System. We are focusing on providing eye care solutions. And I'll be touching on two aspects of our work, uh, one relating to access. So the context is that more than close to a third of the population is in need of eye care. And then the challenge is reaching everyone, since most of them live in rural areas. So the solution that we came up with was to reorient or add to our hospital-based eye care, primary eye care solution, which is in line with the WHO's recommendation of integrated people-centered eye care. So what we came up with was a tech-enabled primary eye care system, and I'll run a short video to show how it works. A patient walks in and then pays the sum of 20 rupees, or about 25 US cents. And a technician there does a complete eye examination, checking for refractive errors. We also check for blood pressure, intraocular pressure, do a detailed exam, very much like what you would get if you went and saw an ophthalmologist. And then all this information is entered into a digital medical record in the cloud, and the technician presents the findings live to a doctor in the base hospital. And the doctor reviews the chart, talks to the technician, then also talks to the patient, comes to a decision about what the diagnosis is. And in this case, the patient got a prescription for glasses. And then we also make the glasses available right at the center itself. Like in this instance, she's trying on ready-made readers for nearsight. Otherwise, they will get the glasses the following day. And these vision centers are in small rural areas, about 500, 600 square foot. They're all in rented buildings. And then within those vision centers, we have made sure that we use low energy devices like LED bulb lights, fans, and so on. And most of the equipment and supplies are sourced locally, thereby cutting down on transportation costs. And wherever it is feasible, we have set up solar power to energize those vision centers. Typically costs about $16,000 to $17,000 to set up one, and about $8,000 to run them annually. And financially, they tend to be self-supporting. Sorry. So in terms of design, we have come up with a one-stop solution so that we reduce the travel and commute for the patient. Like we saw in the video, glasses and medicines are made available right at the vision center. For surgical follow-up, also the patients come back to the vision centers. And we strive to complete all the activities in a single visit. And then also making the care affordable so that they're also not making multiple visits to complete their issues. For some reason, it's jumping to. So what is making this carbon friendly is the telemedicine technology, as well as the digital medical records in the cloud. All patients get a real-time consultation, and all the staff are from local areas. They're trained and posted there, so they also commute far less than otherwise. So 87% of the patients complete the complete care cycle at the primary eye care centers themselves. So today we have a network of 112 vision centers covering a population of roughly 70 million in the southern state of Tamil Nadu. And last year we handled close to 1 million patient visits, which resulted in about 54,000 surgeries and more than 100,000 glasses being dispensed. So this approach we estimated that it saved the travel to the city for about 870,000 people, or about 60 million person miles. More than 1,000 metric tons of carbon emission has been averted. And we also have been tracking the impact of this primary eye care centers, and we based on the service area population and the patients who access the care, we found that about 27-28% of the population has been covered, which really translates to achieving universal health coverage. I'll just touch on briefly another challenge is that as healthcare providers, we are a significant contributor of carbon emission, which I think is the reason for the conference that we are in. So the challenge that we have is how can we play a role in reducing the carbon footprint? And one approach that we have taken is having lean clinical protocols and patient-centric design. Again, even in the hospital setting, we try to complete the entire cycle, of including cross consults. We don't have any waiting time for surgery. They can get the surgery on a day of their preference. We have standard operating procedures based on lean clinical protocols that are based on evidence from our own setting. So our lean protocol uses sharing of supplies. We minimize the use of single-use instruments and other consumables. We reuse instruments after sterilization as per our protocol. And then, like our previous speaker mentioned, we do waste segregation at the point of generation. And we also do a lot of, our mantra is reduce, recycle, and reuse. So you can see what this has resulted in. On the left, you see an image of waste from one surgery in UK. On the right, you see the waste from identical surgery from 32 surgeries in Aravind. And even in this, more than half are recycled. And then our carbon emission is about 5% of what a UK surgery or in the US produces based on their protocol. And then this is done at no compromise to quality. As you can see in this graph, the visual outcomes tend to be better. And then complications or infections are much less in using this protocol. This we recognize is actually leading to a triple win, where the patient puts in less effort, and the hospital, it costs less because of the lean protocols. And then together, it reduces carbon emission in the environment. So overall, it's a triple win for the whole health caregiving process. Thank you.
Thank you, Tulsi, for that presentation. It's just really amazing to see how technology, lean protocols, minimizing those single-use instruments, your local solutions can be combined to provide quality care that is inexpensive to the community, right? And that also helps with last-mile health issues, universal health care. I mean, getting glasses the following day, it takes me in the US about a week, if not more or longer, to get glasses. So amazing to see what you can deliver in Southern India in your eye care system. Thank you so much, Tulsi. Our next speaker is Aziza Rangungwala. She's a medical scientist who coordinates the Global Green and Healthy Hospitals in South Africa and wider region through our partner Groundwork. Welcome, Aziza.
Thank you, Diana. And thanks, everyone. I think I'm just going to put my screen on. As Diana mentioned, I'm the Africa coordinator for Global Green and Healthy Hospitals. Groundwork is the Africa partner of Healthcare Without Harm, just shortly. So I'll talk about some sustainable solutions. I just want to give some context So in Africa, our context is quite different. I mean, only 7 out of 54 countries increased their health spending over the past few decades, and many are actually reliant on external funding. I am based in South Africa, and in South Africa specifically, we're right at the bottom. We have more than 400 public hospitals with a parallel private and public health system. But overall in the continent, rural health is very underserved, especially when it comes to quality healthcare. Oh, sorry about that. Sorry, my mouse is a bit funny. So I'm going to speak about healthcare risk waste management. So healthcare waste is a major cost driver, but it also is a very, it's also a pollutant because a lot of our healthcare risk waste is incinerated. And from incineration, these things, you have your different pollutants that go into your ground systems that leach into your soil. Close to the facility can be exposed directly through an inhalation or indirectly through consumption of food or contaminated water from these pollutants. So in South Africa, we started decommissioning on-site treatment of healthcare risk waste. Hospitals used to have their own incinerators, and they were completely decommissioned for on-site treatment. So we started using external service providers for the treatment of healthcare risk waste. This includes your shops, your pathological waste, your pharmaceutical waste. A lot of expired medicine as well gets incinerated. And you can only imagine the effects of incineration of pharmaceuticals and also how much plastic we have in our healthcare waste. Now, since the Air Quality Act was introduced, that was quite helpful because when you have legislative framework, we can do away with your on-site incinerators. The problem is it didn't do away with the bigger incinerators, and we started looking at measuring our reduced and generated healthcare risk waste as a possible cost saver, reducing our carbon footprint, and also to align our programs to international treaties, as well as the Paris Agreement. So this is just, oh my gosh, sorry for the mouse. Let's try and click through. Okay, so this is a picture of an alternative treatment technology. This is not on site at a hospital. This is one of the service providers that have a very a much larger equipment. It's a frictional heating system that uses frictional heating to reduce your healthcare waste and disinfect it. And what you see on the one picture is basically you can touch it with your bare hands. It can go to a regular landfill. Some people use it for cement kilns, but it might be, false solution as well. So this is one of the bigger machines, and our service providers that treat the healthcare risk waste can also move from these big incinerators, because incinerators also take more that you need a lot more maintenance. That previous big machine is actually from Umpico, and this one is a Nusa system. It's also frictional heating technology. This one is on site at George Hospital in the Western Cape in South Africa, and it can be operated very easily. We have one technician looking at it, and you'll notice that it also does frictional heating, and it is tested using vials to ensure complete sterilization. The reduction in volume is about 1%. And it's complete disinfection. There are also chemical treatment processes as well for different machines. One of our other private hospitals decided to have this. It's housed in a very small container, as you can see in the photos. They use chemical treatment processes, chemicals. Chemicals we're a bit wary about because if certain chemicals can contaminate your water systems, and drinking water purification systems are not always that accurate. So there are a couple of considerations when it comes to healthcare. When you're looking at moving away from incineration, because to be honest, we will not be incinerating in the times when air pollution is such a major crisis. And as the health system, I think we have the mandate to move away from incineration. So we look at certain considerations when we did the research about operation and maintenance requirements, what skills are needed for operating the technology, who do you hire at your hospital to look after it, what are the infrastructure requirements, do you need a separate room, how much space do you need, We're looking at location and surroundings. When I mention reclassification, we mean how do we get to classify that, the shredded substances to not be classified as medical waste anymore because it's been disinfected. It can actually go into a regular waste landfill. It doesn't have to go to this waste landfill anymore. And this is an issue with legislation that we're trying to work with as well. We also have to look at public acceptability, regulatory requirements, as well as permitting, because there's lots of, this is, when we're looking at alternative treatment, there's different permitting requirements of how we can operate. There's also the capital cost of the equipment, because I think that's the highest. We import a lot of this technology, actually from Europe. So I think it would be interesting to see how European hospitals adopt this. Rating and maintenance costs, and looking at shipping, customs, installation, transport and disposal, and decommissioning at the end. What happens to these machines when they no longer work? Because then they become electronic waste of some sort. So when we did research on the various treatment technologies that are available in South Africa specifically, we looked also at ones that are not yet available, can be imported. And the electricity consumption is very important because we do have electricity scarcity in South Africa specifically, but also across the continent. So looking at electricity consumption of these machines, the kilowatt per hours range between 0.2 and 40, depending on the treatment capacity. We look at water usage because we're also a water scarce country as well. And the liter cycle range between 0.05 and 80. And there's also possibility of reticulating grey water for use in the machine. We ensure that there's complete decontamination, like spore kill, and complete microbial inactivation, which is also important, especially in regards to when we have pandemics and we have certain outbreaks. And I mentioned earlier the space requirements. So I want to zoom in a bit about pricing because people think incineration is cheaper. Incineration is not cheaper. It's at the expense of our health, firstly, but it's also more expensive if you look at incineration, including transportation of consumables, because sometimes the major incinerators are far from hospitals, and like I mentioned, the rural areas are underserved, and the transportation alone has a very, very high carbon footprint. Now, that can cost you between $2 to $4 per kg, US dollar, not euro here, oversight on my part. But the dollar is, I think, similar to the euro rand. So, and then the frictional heat actually worked out to $1 per kg. There's also low heat thermal processing, which can be much cheaper, like a quarter or less. Steam sterilization and maceration, also a quarter or less. So it does show that these technologies can be much cheaper. So when using these technologies, we look at how plastics are becoming an issue just generally. And I just wanted to mention, away from treating healthcare waste, single-use plastics and plastics in general, plastics have a high calorific value. When they also do get incinerated, the byproducts from incineration are very dangerous to people's lungs, and people usually live close to these incinerators. So just wanted to mention that's even an added layer of the health. And we are working on doing plastic audits to define what type of plastics are available, which ones should be in the shredder, and which ones should we take for recycling rather. And that's something that's legislative, because speaking about pharmaceutical waste and empty medicine bottles, depending on how much is left. A quick one before I end, just to go touch on renewable energy. We have our private healthcare institution that had some really interesting stats on using renewable energy. The reduction has been much per bed per year, 10%. Energy use has shown there's been a smaller reduction because of the pandemic. We had a bit, not like a total reduction, because we had all these waves of COVID, and a lot of PPE was being used for the alternative treatment of waste, and a lot of energy was used because of lots of patients. But it was definitely shows a return on investment, and these are in rands. I apologize, but it's big amounts, and it's huge cost savings. Like, for example, for renewable energy, the 28 million rand cost saving is basically, you can buy in a very urban posh area in Johannesburg, you can buy 28 houses. So I'm going to end there, and I just like to urge everyone to, to engage, ask questions, and I think we really, really need to move away from incineration. And I really believe in alternative treatment technologies. We've adopted so many other technologies in our medical system. We also have to think about the waste as well. Thank you very much, Diana. Over to you.
Amazing, Aziza. Thank you so much for sharing that experience and the lessons you're learning about these alternative methods, right? These alternative treatment of medical waste, moving away from incineration to protect public health and the connection that has with the regulation, not only in air pollution and local or national regulation, right? But the wider environment of global regulations and how that all fits together will also be necessary. And to how do we apply those lessons, right? Those lessons that you're learning through your operations to a wider network, to a wider environment of regulations as well. Really, thank you so much for that, and thank you everyone for your presentations. I think that they have captured quite a bit of the challenges, the work, the solutions that you're seeking with this audience. So I'm gonna start off with some of the questions that may have been posted in the Q&A and the chat. I know, Dr. Glenn, you sort of answered a question on the Q&A section, but maybe you can expand a little bit on that. This question is for Dr. Glenn, and it says, could you please expand a bit on what exactly was the reprocessing PPE program in your hospital? Reusable gown masks or recycling plastics? And comes from, from David Renard.
Right. So am I coming in clearly now? Okay. So as I was answering, it was actually looking at the usage of chlorhexidine. Right? So what we would do is that we would put the gowns and soak them in chlorhexidine, and then after which we would autoclave the gowns so that we would only use them twice, and then that's when we dispose of it. So there were disposable gowns, but up to I think we just used one time. But what we did was to soak them in chlorhexidine and then did an autoclave, and then we used them for a second time. So those were for the reusable gowns and masks. For plastics, what we did was actually to recycle, not to recycle, but rather to segregate properly. Because we had to have a lot of education for our patients, and they were just putting them in the black and green plastics, or putting them actually in the yellow plastics, which is infectious waste. But upon opening them up, we were looking at they were supposed to be in the black and green plastics and not in the yellow plastic. So just to come up with a education program for segregating and proper segregation, we were able to lessen and then just put the medical wastes in the proper bags. So that we were able to lessen our waste with plastics.
Thank you so much. Thank you so much, Dr. Glenn. I have one question here for Tulsi from Marianne Kalimag. Are you still reprocessing single-use instruments to 5 times usage?
So in our case, I think the surgical instruments are all reusable. So they are used for many more times. Between each surgery, they tend to be sterilized as per our protocol. So at the beginning of surgery, we do a long cycle sterilization. And then in between surgeries, we do a short cycle, what we call as flash autoclave. And then the surgical instruments are all metal based, and they last for many more than 5 surgeries.
Thank you so much, Tulsi. I see a question here from Claire Topping that, while it's directed to Aravin and to Tulsi, I think it's actually a good question for the 3 of you. So Claire, thank you for your question. I'm going to expand it a little bit. She says, I have used the example of Aravind in teaching about innovation and sustainability. I don't understand why it isn't a model adopted more widely. What is stopping us? Why can't we, even as we share right now with our European health facility, health system colleagues, what's stopping us from adopting these solutions? Whether it's waste or energy or just the way that we do business. Tulsi, first you, and then over to Aziza and Dr. Glenn.
I'll make one brief point, and I think usually what comes in the way of adopting what works in the South is normally regulations. And in my opinion, many of the regulations are not really evidence-based, but what a colleague of mine called as eminence-based. So I think that is really what comes in the way when they come up with protocols and again, there's also a tendency to do a one-size-fit-all kind of thought process. So the regulations that they come up with are usually for probably the most stringent, complex surgical process, which takes up 8 hours or 10 hours. You need a certain protocol for minimizing infection in those conditions. And when you apply that to a simple surgery, which is done in 5 or 10 minutes, then you're actually over-regulating what is required. You spend a lot more, but then it doesn't do anything for improving safety or outcomes or infections. So to me, that's one take. I'm sure Glenn and Aziza will have other insights on this.
Dr. Glenn, you want to go ahead?
Right. I think one of the reasons that there's not really that uptake yet from the north. Did I get the question correctly? There's a poor uptake of the solutions in the north, right? Is that correct?
It's about how the solutions that perhaps we are seeing in the global south, right? Why aren't they being adopted more widely? We see some really great examples in what you guys are doing.
Maybe I'll take that other point wherein their resources are a lot. Okay? And because there's a lot of resources in the South, since we become more creative in our resource allocations. And I think because of a lot of resources, it's not a question of resources in the North. So that is not a solution for them, right? But if you will look at, because of that limitation of finances, we tend to be creative. So that's another take on the effects on the environment of what we're trying to do. So it's two-pronged again. The effects on the environment, we look at them long term, but the other is because of limited resources, we have to be as creative as possible. Is what we have.
Thank you, Dr. Glenn. That's interesting too, and how the resources and regulations, as Lucy said, can work against and for us as opportunities as well. Aziza, what about you? What do you think?
So I think generally our health systems have, well, this is just generally in all disciplines where people are not sure about change, and there's always the risk about infection control. I think I saw it in the chat about speaking about infection control. But I think, looking at the Aravind system, the infection control has been tested. So it just shows it's the same quality healthcare, except you're not using single use. And like single use items, end up in landfills, eventually, even if they're incinerated. So I think perhaps when there's a comfort level of how we've done stuff, and this is your SOP and your standard operating procedures, you're often not sure how do we make that change and taking that step when you're not challenged, maybe not forced. Force is not the right word, or challenged to change. So perhaps looking at that uptake, I think when health professionals themselves can tell the people who are doing the administrating and the finances that we would like to procure something different, we would like to test something different, then it would probably be easier, because the people who make the decisions work on a very business model of health. Yeah, that's how I see it, Diana.
Thank you so much to the three of you. And for our audience, I really hope that we've shattered some preconceptions you have had. Often I hear, the Global South focuses on
Diana,
adaptation.
you're muted.
Oh, am I? I hope that you can hear me. No? Okay. And I often hear that the Global South only focuses on adaptation, and mitigation is a very northern thing to do, but it really isn't. We really have seen how health facilities and health systems in the Global South are really taking action, and really in very creative ways, in ways in which I hope we can see they can also be increased and adopted by other regions and other countries. So I also hope that this inspires you to learn more, and to learn more about the other regions of the world and what they're doing.
Can you hear me?
I do hope that I've come to the end of this session now. Once again, thank you so much to Dr. Glenn, to Tulsi, and to Aziza for participating in the session and providing us with these concrete examples of sustainable practice in the Global South, and showing us the challenges and opportunities, of course, that we have in the creativity that we can also exert in the sector. Thank you all of you for joining us today. We invite you to keep this conversation going via the chat box or connect directly with the speakers and your fellow attendees via the platform. A couple of advertisements here. Coming up next at CleanMed Europe, we have the session on collaboration for biodiversity at health facilities, which will begin at 13:15 Central European Time. I would also like to highlight another session we have coming up this afternoon at 1500 hours Central European Time. The session is called Building Healthcare Climate Resilience. And on Friday at 10 o'clock Central European Time, we'll have Sustainability is Not a Hobby. So a very serious one, I'm sure. So thank you so much for your attendance, and I hope to see you again next year. Take care.